Welcome to the Reality Check. Psychosis is real, so is recovery podcast.
I'm Dr. Ashley Weiss. I'm a child adolescent psychiatrist.
And I'm Serena Chaudhry. I'm a clinical social worker.
And we are the co-founders of EPIC-NOLA, which is the Early Psychosis Intervention Clinic in New Orleans, and also the co-founders of CALM, Clear Answers to Louisiana Mental Health.
Hi, good afternoon. Welcome to Reality Check. Psychosis is real, so is recovery podcast. Today we have with us Chimela Soublet from Xavier University Counseling Department. Chimela, can you start by sharing a little bit about who you are and what you do?
Okay, hi, thank you. I'm Chimela Soublet. Once again, I'm an LPC-S here at Xavier University Counseling and Wellness Center. I also do private practice with Headway on the side, a little bit of that part-time because my job here takes a lot of my time. But I've been at Xavier for going on 5 years, but I've been in LPC for about 9.5 years.
Okay. Well, that's cool. So for those people that might not know what an LPC-S is, maybe you could share that.
I'm sorry. We're so used to our acronyms and we don't explain them. Licensed professional counselor, licensed professional mental health counselor. Yes, that's what that means. I've been trained in that area. I received my master's of clinical mental health counseling from University of Holy Cross back in 2014.
Very cool. I like to remind people that there's so many ways to enter into the mental health field and lots of different letters.
Yeah.
But all
It won't spell out.
But all for the greater good.
Yeah. And then I guess on that note, just for those who aren't familiar with mental health services at a university level, can you just tell us a little bit about how mental services are offered and how they operate at Xavier?
Yes, we do function as a fully functioning Office of Counseling department, like a center, but it's very clinical. They come in, they do an intake process with our office care coordinator, which is Ms. Sheila August. We do try our best to let all of the parents, incoming freshmen, know at like orientation what we do, where we are located, so they can know as soon as they get here on campus what we do and where we are and how to find us. But once they come in, they do an intake. We also take referrals from faculty and staff as well. Sometimes the faculty member may see a student that just needs to talk to somebody and they'll say, okay, here's a counseling center. This is where you need to go. And then they call us and then that process is done. But we have 4 clinicians, 3 LPCs, licensed professional counselors, and 1 LCSW, which is a licensed clinical social worker, and our director, Dr. Gant, who is an LPC as well.
And I'm curious, in the time that you've been with Xavier, do you have a sense of where your referrals come from more often, faculty or student self-referrals?
A large amount of them do come from student self-referrals, actually. We have found on our campus that the word of mouth piece is very important.
Yeah.
The students here, when they connect with you, and if they're having a good experience, which I hope they have, they will share with their friends. And so a lot of times in our caseloads, we may have people say, oh, my friend came to you, they told me about you, which is a good thing because we want them to know that therapy is okay and that is to reduce that stigma of mental health.
Yeah.
We've done a lot of preventive things on campus or just, I think, trying to advertise. Like last year, we had a campaign saying it's okay to not be okay. And it was like we had signs everywhere, decrease the stigma. Because of what I realized when I got to Xavier was that some students didn't even know where we were, which we had to work on getting that out there. I didn't know what happened before I was here, but so now a lot of them know where the counseling center is. They'll bring their friends. But we do have, I would say, about maybe 35% of faculty that will refer as well. We're trying to work on that as well to get them more acclimated to letting us know what's going on with students and sending them here.
Do you guys, I guess what has been a little bit of background about me. Oh, my first job out of fellowship was at the Uptown campus at Tulane. I was one of the psychiatrists there. And then when I got more into education and medical education, I had to leave because couldn't be the psychiatrist for students, like potential students that I was teaching. I went there specifically because that's where the age group is where psychosis starts. And so I was like, oh, then working on a college campus would be great because this is where it starts. And it was really hard to keep people in care though long term at a college campus that's having new people in every single year. It's a lot to keep up with. But when it did work out well, it was really awesome to be like their person on campus that they would be able to come to when things were bad, especially during finals time. They'd
Yes.
schedule appointments because they weren't sleeping well, things like this. But I'm just wondering your experience with onset of serious mental illness, psychotic disorders at Xavier.
Yes, and I'm so sorry. I forgot to mention we also have a psychiatrist that's on staff as well. He's here. His name is Dr. Mangott from Monday, Wednesdays, and Fridays.
That's cool.
He's not here every day, but
That's really awesome.
we do have a psychiatrist that's on staff. There may be some changes coming up in the fall because Oster's taking over our health center side. So we don't know if he's going to still. They may have their own psychiatrist coming in, but we have told them we still need a psychiatrist, so please do not get rid of him, or someone. But that piece, what you mentioned, was so important, Dr. Weiss. I'm saying it correctly?
It's Weiss, but I
Weiss, I'm sorry,
respond
Dr.
to
Weiss.
both.
But no, that you are so correct. I know you already know this, but just saying that about the onset of some mental health issues, we have really seen that it does even sometimes come on when they're like 22, 23. Bipolar disorder, or bipolar depression, sometimes it doesn't manifest until those ages, or once they're already here.
Right.
So some students that we've had experience with have maybe felt like something was not working well, but just did not know how to seek the help. We also find that once what we've done here, once they are diagnosed or with something like that, or if they come here with a pre-diagnosis as well, we try our best to follow with that care and continue whatever therapeutic needs that they may, any type of therapeutic needs that they may require, but also having that resource like Calm and having an outside resource that can help them when we can't do it here, because we can only do so much on a college campus, being with
Right.
our restricted hours and all of that. And sometimes that is a struggle, I find, with the scheduling piece, because they may want to do it, but I have class, or that's what they hear in college, we know, but or they just can't. Or sometimes it's transportation is the issue as well. It can be a barrier to them getting the help or getting off campus to those referral resources. But sometimes when we have like wellness events and we can put a face to like a Calm, and when they come sometimes with a representative or like River Oaks or someone else like from any other agency, that kind of helps the students to know, okay, there's a human behind his name, and they can relate a little bit better. So I think as long as we continue to do wellness events like that, to push that information out there and give them information that can help with their needs.
Yeah. For sure. And you all are a great example of what community partnership can look like. I think, right, these wellness events that you all do on campus, the active communication that happens between your counseling services and, say, for example, our clinic, EPIC-NOLA, has been ongoing and evolved so much over the years. And I remember this is probably 7, 8 years ago, Dr. Gant referred a patient to us way in the beginning when we had first established ourselves as a clinic. And at the outset, the referral process was really smooth because y'all knew what the criteria was for someone to be referred to our clinic, followed up on the referral, and then engaged with us throughout. I would check in with Dr. Gant. Oh, I'm just remembering all this now, on a monthly basis about this student. And it was a way to support them while they were in school. And so I think it's inspiring to see that we have worked together for so long, and I believe done really well for students and helping them to move through the college process. You mentioned something that I do think is also real: transportation and accessing resources off campus. And I remember this one student in particular that definitely was a barrier. Fortunately, now we at EPIC-NOLA have a van that is able to help in instances where transportation is an issue, because though you're not far from us in eyes and lives of a college student, you are very far.
Yes.
The whole 2 miles. So I have this fly that's circling my head, and it's slightly distracting, but it's like you're talking and I'm like smiling because I'm about to bust out laughing. Serena is too, because it's
But that can be so aggravating.
I don't know if
Well,
you can see it, but
did I like leave food in my hair or something? Like, why is it circling? Why is it circling my head? Anyway, I'm trying to swat it when we're not talking. Oh goodness. So I guess I would like to talk about. Well, I talked at a Senate hearing a few years ago about the struggles with transitioning from high school to college, especially people that had their first episode of psychosis in high school already had established care. They had a care plan. They had accommodations in high school.
Mhm.
And so that journey to go to college, where all of that doesn't translate into a different setting. And some of the topics that came up, well, for one, why not?
Yeah.
If you've already had testing, you already have a diagnosis, you have a medication plan, a therapy plan, then why do you have to reinvent the wheel once you go to a college setting, especially especially for accommodations? Like I
Mhm.
get it getting established with a new clinic and stuff, but if you're already know what it takes to help academically, then
Mhm.
why do I? And sometimes it costs so much money out of pocket
Yeah.
to get that kind of testing in order to determine academic accommodations. And wouldn't it be lovely if it could more easily translate,
Yes.
especially for the student?
Oh, yes. I totally agree with you on that, Dr. Weiss. We do a lot of communication with our disability services office because a lot of times our offices are connected, of course, by the nature of it. We have really tried to explain to students who are coming in with accommodations needs the process, what you have to do to in order to get the accommodations in college. Some of them don't even know that they can still get them in college, which is really strange. I used to be a high school counselor too before I in education and doing private practice as well. But so I saw that other side of it and knowing the laws with Act 833 and all of that. But some of them they're not even aware that they can still receive and they'll struggle like for 2 years and they're like, oh, I could have had this. So I think there is a gap somewhere. I don't know in that piece of providing information for them. And yes, it is a strain. I think for them to have to go through all of that all over again, and then finding that piece. Because for us, I think the process is okay. So once they get the diagnosis from an outside provider, because there is some type of stipulation. Y'all know universities, there are also systems as well. So we did have a psychiatrist, but he was in his contract, he was not able to do ADHD assessments, which was a huge issue for us because a lot of our students had
yes.
so we did have some private contractors or I'm going to say separate referrals that we would send people out to in the community. And it would tell us, oh, come on. And people came to us as well. So that was very helpful. But it was still a barrier for some students regardless because some students, once they come here, they just want to stay here. They don't want to go anywhere else. But that is so true. That piece about that linkage between can I continue my services that I had? I'm still going to need them, and sometimes in college even more. And we also find that sometimes faculty isn't as understanding with that. So that's been I think a push for our director of disability services, Miss Campbell. She's really tried to educate them on the law and some things have to be in place regardless of what you may think and not making that student feel ostracized because they have an accommodation. That is huge. A lot of them and sometimes the rule I don't know if it is where you guys have worked or know about other college campuses, but and most of the ones that I know of, and we go to other conferences as well, we see the same thing. Some of it is once they are granted an accommodation, they can't just pick and choose when they use it. They have to use it all the time. They can't say, oh, I'm feeling like I don't want to use it today. And so we try our best to help them recognize and advocate for themselves, but also reducing that stigma of the learning curve about accommodations because it's because I have an accommodation doesn't mean I can't learn. It just means I learn a different way than you do. Or I may need an extra piece of extra time on test anxiety or whatever that may be. So a lot of times those students who get those accommodations, they also come to us as clients as well because they are suffering with either depression or some other type of multi-level diagnosis that may be affiliated with ADHD as well. Anxiety and depression is one of our most common ones with adjustment disorders.
Yeah. So I think for any listeners or younger listeners in particular, if you're graduating from high school and moving on to college and you have accommodations there, the transition doesn't have to be difficult. It can be smoother and fluid, really, in working with your existing provider and then with both disability services and with counseling services on campus.
Yes.
But not all campuses are as lucky as Xavier to have full service clinics on campus. And I'm curious, in the work you do and in perhaps other campuses you visited, what suggestions would you give to listeners who are on a campus where there aren't these services available?
The first thing I would suggest is for that particular student to actually try their best to ask someone in the administration or the advisory committee where the counseling center is, if there is one, or where is the disability office, because that is what that those are the places that they need to go. And we know sometimes that is, like you said, even for our kids here. I mean, we have that, but it can still be a barrier because, or I would say, an uphill battle, because sometimes they may know where we are, but getting them to come to those doors is a little bit difficult. So that's why we try. And I would also suggest for them, once they find out where those locations are or who is the person to speak to about applying, or with the web, most colleges have a website for disability services separate from counseling, where they can go in and just apply and say, I am such and such. I am applying for this type of accommodation. Now, I forgot how the form is set up exactly, but so that's the first step. And then the disability coordinator or director reaches out to that student to say, okay, this is what you need. I want you to come in at this time or whatever, so we can discuss your case. And then so it could go. I don't know the exact procedure, but I know that's how it starts. So once that is done, they can know who you are, and then you can see what you need to get the paperwork or whatever documentation that is in. And I would say this: that documentation piece is very important. If you don't have the exact documentation that they are requiring, it can cause you to have a prolonged time of getting your accommodation. So for students who are just entering college, that email is important. They do everything by email, and you have to read it daily. And if you're looking for a response for someone from a different office or whatever, that's an important tip. But I would say at least find out who those people are, because those are the people that can get you to the other people that you may need to get linked to get your services.
Yeah. No, that's super helpful. Thank you for walking us through that process.
Yeah, a couple of campuses I remember being more involved with, like in that other psychiatrists and mental health services with other campuses, and going to, I think it was University of Mississippi, but talking about the sheer volume of people coming through their doors and really having to be kind of time limited in how many sessions that people could have, and then what to do when you're referring to an outpatient provider when the city or town doesn't have a lot of outpatient mental health clinicians. So they were just inundated, and it becomes a kind of a resource issue that seems to be still conversations on college campuses, is how much do we provide and for how long, which is, I think in an ideal world, it'd be awesome to have, you know, your medical home on campus for your life there, especially living in the dorms and stuff where you're like, don't have a car and you're walking around. But then when you need specialized services, like for instance, when you guys refer to us, not every city has a first episode psychosis clinic, and it's so hard. I'd really like to know what your experience has been like making a referral to EPIC-NOLA, and like you know, what you've said to someone, how you've described it, because that is like a huge pivotal time for us, because the person making the referral really has to do it in a way that the person is going to take you up on the offer, right?
Right. Right. I did have one student I referred. I remember a while back who was, I think she was diagnosed with bipolar schizoaffective disorder. And this was well, before I even go there, I want to say that piece you said about the limited sessions. That's an issue across the board. I think across college campuses based on our caseloads. We just tallied up our numbers for the year for this past fall school year, and each one of us had seen at least 300 students. That's a lot for a 4 semester.
Wow.
So, and we do have a limit, which is 12 sessions per school year.
Oh, okay.
Sometimes we can request more depending on the case by case, and we just get, we have to go to a director, Dr. Gann, to say, the student may need more sessions, because of the need. And if if we can work it in our schedule, we will do that. I also will say that piece, for some students, it works well. However, but back to the student I had that was with the bipolar skid. So this was a client I had who, she just graduated. My God, I was so happy and proud of her. Just
Aw.
past May,
Aw.
she's come a long way. But she had gone to a mental health professional before she came to college. However, she had very, very negative experiences with them. So she came in resistant.
Right.
So, and resistant to labeling her diagnosis, which, we never want to label anyone, of course, like, in a negative way. But when it came down to her realizing, she was very self-aware, but knowing she was going to these huge spirals up and down, so much it became, and academically she was doing fine, but mentally she was struggling. So which affected her academics sometime. But in her case, the therapeutic relationship that I developed with her, where she was able to trust me, that was very important. That therapeutic rapport, I think, is very important, especially with this age group, because they are so delicate. They are so worried about image and all these things that I didn't have to worry about when I was like 20, like they're, but it's also, and so for her, I would say, from my particular experience as a clinician with her, as we worked through some of that resistance, through our therapeutic relationship, she was able to, we did refer to our psychiatrist here. It wasn't a good match. It was something, I don't know. He's a great psychiatrist. It was just, it was she wasn't that happy. So we referred to a different one, and she liked that one. So, and when she first got like officially diagnosed, and I even told her when I did a warm handoff, because we try to do that when they're here, a warm handoff, bring them to introduce them to the psychiatrist, and tell them, this is for further assessment. It's not, to make you feel any worse. We want to get you more help, more resources. I think as long as the clinician is doing that to help them feel like we are here to help you get more access to better care, that's important for them to understand. And once she understood that, she was more receptive to trying medication too. Because at first she was like, I don't even want to think about it, but I know I need something to help me. And so we never, of course, forced that on anybody. But in her situation, once she did get on medication, she became much more stable. I think she did go to EPIC. Oh no, I was going to refer her, but her schedule would not allow her with the timing. It was just, her schedule was crazy at the time. But I did give her the information. And but usually, like you said, the one that Dr. Gann had referred you guys to, we really try to explain to them what you guys do and how supportive you are in their journey. And I think that is very, very important to rely to the client, because we don't want them to feel like we're just pushing you off somewhere. We're still here for support. It's a team of professionals that want to help you. It's not like, oh, you go there and I don't want to see you anymore. So I think that's important, that rapport and developing that trust with that clinician, so they can feel as if so they can feel comfortable enough to say, you know what, okay, I trust this other entity to help me.
Yeah. And I think I just like to emphasize a couple of things. You said the teamwork, right? This is a team effort. And our goal for everyone who walks through our door is to help them get back to living their lives, right? Like the fact that you identified that this individual graduated and how excited you were, right? That's a huge win for everyone. And we celebrate all these milestones for our patients as well. And you also mentioned the having the warm handoff. I think that is huge, because this is a really vulnerable time, right?
Yes.
When people receive these diagnoses or experiencing these symptoms, and to demonstrate that teamwork is real, right? Getting them from one provider to another and demonstrating that there's trust in the room, so to speak.
Yeah, it just made me kind of go back to like the early detection piece, and thinking well, I'm not supposed to say I'm thinking anymore.
Mm.
No,
I
that's got
just
to be
edited
out of.
myself earlier.
You did? I know. I'm trying to edit myself because it's ridiculous. Keeping the balance when you have someone that is having their first psychotic episode, not severe enough to have to go to the hospital, but they're having psychosis symptoms. And you, as a clinician, knowing like, oh, good, like this is, you know, super high risk time. This person needs to get to specialized care ASAP, and k- keeping all like both those balls in the court in your mind as a clinician of, yes, I've got to develop therapeutic rapport, keep, the person's perspective and choice like in the room, but also this is super serious and this is something that we need to get you to the right care, not next month, but
Mhm.
this week, next week, knowing the risk of how psychosis can become more impairing, to where someone might end up in the hospital. Because ultimately, our dream, like, or not dream, but belief is that one should not have to experience psychosis so severe that it requires a hospitalization. And so I think as, clinicians in the room, keeping that balance of trust and rapport and also seriousness and a sense of urgency is so important. And in a skill, like it's hard. It's hard to do those things.
It is. I totally agree with you because that, and I think too, I want to bring this up. I don't know if we have much time, but the struggles that students had with substance abuse on campus, such as marijuana and alcohol as well. I just recently went to a HEC conference about maybe 2.5 weeks ago, and one of the speakers presented on that and talked about how much, which we see it every day, but just having the data and the statistics really helped us, which we had before, but just updated information was very helpful. But that's been, I think, a struggle for us, even when we do presentations on campus, because a lot of the students, we know people they're going to indulge, right? In college, they're going to do things,
Mhm.
they're going to try things, right? But the marijuana piece, sometimes what's going on today and how it's being laced with all these different things
Mhm.
can cause psychotic issues. So this year, as we came to the table, what we did with our consultation meetings with Dr. Gain and other clinicians is we talked about how maybe we can do some presentations in the upcoming fall related to just information wise. We're not judging you because you're
Mhm.
doing it, but we want you to know what the information is, because a lot of them, what we found in the audience is saying, oh, it's fine. Oh, I'm not addicted. Oh, I'm not going to get that. It's not going to happen to me. But we've seen it
Mhm.
happen. It happened to
Yeah.
a student that we know, one of my other previous clinician that worked here, one of her clients, it happened to one of her clients. So, and I know someone personally that it happened to as well. So, and that can be very serious, and it can be, it can change. It can be mind altering if you're
Yes.
taking something that you don't know you're taking, and the doctors told us then that it was the synthetic stuff is so hard to trace. It's very
Mhm.
hard to treat.
Mhm.
So sometimes it's a time thing, and people may come out of it, or flushing it out of your system with IVs and fluids and all other things they do medically. But just having that sense of not, I think that piece of knowledge for them is very helpful in this generation, because I see it even my own. I mean, I have young adult children as well. They don't indulge, but they have tried it before.
Mhm.
So just give, as a parent, even say,
Mhm.
hey, be careful. You shouldn't do this. I mean, thank God they only tried it once or twice. They didn't like it, but still. But with our clients, I think that's important to our students as well on the college campus, to have that piece of information, or that educational piece about what is happening in the
Yeah.
data and the statistics, because we know that sometimes it can lead to schizophrenia if you have over,
Mhm.
a lot of people who are doing it not medically. Just indulging or trying to self treat.
Mhm.
Yeah.
Yeah,
We
for
did.
sure.
This is why we did this billboard. Can you see?
Oh,
It
I
was
love that.
yeah,
Right?
it was up in New
That
Orleans.
is that's awesome.
Right.
Yeah, maybe
We'll
we
put we'll
could
make
talk
some
about get
we should make some cards and drop them off
Yes.
on
yeah,
campus.
or see if
Yes.
we could get a billboard near Xavier. This
Yes.
is
Yeah.
the whole goal of Calm is to educate and raise awareness with some of these facts and details that just aren't in the minds of young people or their families.
Yeah.
And
Yeah.
Mm-hmm.
Yeah.
And the myth that marijuana itself, even unlaced, can lead to psychotic symptoms. This is we're really trying to think about a group, to have a group happening at our clinic that's very marijuana focused, of
Yeah.
just kind of the real world information about it and some of the statistics and
Oh, I totally
research.
agree with you.
Yeah.
I totally agree because that, but even with the unlaced, I mean, I'm reading the statistic that I had from that conference, and one of them was about cannabis, and it said that cannabis use associated with risk of psychiatric disorders by Hall. It's a study done by Hall and Degenhardt, I think. And it says schizophrenia, those who had used cannabis 10 times by the age of 18 were 2 to 3 times more likely to be diagnosed with schizophrenia. And 13% of schizophrenia cases could be averted if cannabis use was prevented. That was huge to me. I was like, oh my gosh, I mean, we knew this, but just to see it up, like on the screen, we were like,
Right.
they need some psychoeducation about this.
Absolutely. Right. And if you have a family history of psychosis, you cannot be using, right? Should not be using. And this is like we have to on a daily basis, right? Consider how we talk about this. And it's not wrong or bad in totality, but when you have a family risk, it's not for you.
Exactly. And, I think
layering risks.
Yes. I mean, and incorporating other ways to cope. Because now what I see in this generation is they don't want to cope with anything. It's just, they just want to numb it. You know what? I have a problem. I want to just get rid of it. But you have to learn how to be in the midst of the problem, cope with the problem, and learn how to come out of it without relying on something that's going to just make you feel numb.
Yeah.
Yeah, definitely. Well, we're excited to continue this collaboration that we've had going on for many, many years. And some of the joys of our calm adventures is being on Xavier's campus. And so we look forward to seeing you all this fall with perhaps some new messaging, definitely some old vintage messaging that's still relevant today, and maybe to seeing you in person.
Yes. Well, thank you guys for having me. This was awesome. I loved it. You guys were very, very welcoming, and I appreciate it.
Thank you so much. If you have a like Instagram handle or anything, please email it to us so we can tag you and collaborate with you on social.
I will.
Okay. All right.
Thank you so much, Chimela.
Okay. Thank you guys. Have a good day.
You have a good day.
Until next time, thanks for taking the time to get your reality check. And remember, psychosis is real, so is recovery.
If you have enjoyed this episode or found it useful, please subscribe wherever you get your podcasts from and check out the website calmnola.org